Hi everyone, this is Anurag again. I know it's been a while since my last video and I apologize for that. I am back again and I will try and come up with videos more frequently as my schedule allows. One thing that I want to start doing this time around is start with a good thought or a good thing that happened to me during the day. So, one thought that I came across was funnily from Harry Potter, and I've been a big fan of Harry Potter. And that one thought was happiness can be found even in the darkest of times if one only remembers to turn on the light. And that was said by our very own Albus Dumbledore. And kudos to you if you know which book it is from. So, with that thought, in mind, let's go on to our lecture. So today we're going to be talking about classic Hodgkin lymphoma. Classic Hodgkin lymphoma is a germinal center B cell neoplasm which is characterized by scant large neoplastic cells in a background of reactive immune cells. So important thing to remember is that the neoplastic cells will be scant, that is there will be few and scattered, and the majority of the cells in the background are non-neoplastic. So let's start with the clinical feature, localization and epidemiology. So importantly, it predominantly affects the supradiaphragmatic lymph nodes. So supradiaphragmatic, what this means, above the diaphragm, so which include the cervical lymph nodes, the supraclavicular lymph nodes and the mediastinal lymph nodes. uh, there are a few cases, I mean, like as we know in medicine, nothing is absolute. There can always be few cases, that is almost like less than 5%, which have exclusive infradiaphragmatic involvement as well. But most commonly, it involves lymph nodes above the diaphragm. It is more common in males, except one subtype, which is the nodular sclerosis subtype of classic Hodgkin lymphoma, which is more common in females. There are two age peaks that are seen, that is, it occurs more commonly at two peaks of ages. That is, first is the young age, that is from 25 to 35 years of age, and old, that is starting at around 60 years of age and up. Then there can be extranodal site involvement, for example, the lungs, the bone, liver, and the bone marrow, but they're usually seen in stage 4 of the disease. So, clinical presentation, they usually present with a painless, firm peripheral lymphadenopathy, and a contiguous involvement of the lymph node is very characteristic of this disease. That is, lymph nodes close to each other are continuously involved, and sometimes they can also often be matted together. B symptoms, which include like fever, weight loss, nausea, vomiting, or other symptoms, they can be seen, but they are rare. Then mediastinal involvement can also cause compression of the structures there. So if there is like a large mass in our mediastinum, that can compress the airways, that can compress the vessels, so can cause superior vena cava syndrome, can cause cough, can cause even like pneumonia because of the mucus and the organisms are not being cleared because of the bronchial compression. So compressive symptoms. Another very characteristic finding, although it is not seen in all cases, but if it is seen, is quite specific for this disease. It is like alcohol induced pain in the lymph nodes. That is, people drink alcohol and they start having pain in their lymph nodes, which is kind of very specific for this disease. There can be certain paraneoplastic phenomenon which can be seen, and childhood EBV, that is Epstein-Barr virus, that is and this childhood EBV infection is called infectious mononucleosis, increases the risk of having classic Hodgkin lymphoma in the future. So as I was talking about, there are four main subtypes of classic Hodgkin lymphoma. There is the nodular sclerosis, the mixed cellularity, the lymphocyte rich, and the lymphocyte depleted. And we will go over each of these subtypes, like how do they look like, what are the various features. So clinically, differentiating between these subtypes may not be very relevant considering the current chemotherapy, but these are biologically different entities, and it is important for us as pathologists to distinguish between them because they are basically biologically different entities, although they may not be very clinically relevant at the moment. But you never know, if there is any future research which we find certain biomarkers or certain therapy that can be targeted to one of the subtypes. So that is why we continue to subclassify them. So at a macroscopic level, let's talk about the histopathology. At a macroscopic level, lymph nodes are enlarged, They are enlarged, firm, and discrete. In nodular sclerosis, the nodes may appear nodular and, like as the name suggests, nodular, and are often matted together. Whereas in the mixed cellularity and the lymphocyte-rich subtype, they are homogeneous with a fleshy appearance without any specific altercations, and necrosis may be present, especially in the areas that have large amount of the tumor cells. If there are any splenic lesions, there can be scattered nodules, or they can present as large masses in the spleen. Now coming up to microscopy. So first let's talk about the most important, that is the neoplastic cell. They have the characteristic Reed-Sternberg cell. So Reed-Sternberg cell is 4 to 5 times the size of a lymphocyte. It is multinucleated, has a characteristic eosinophilic nucleolus with a perinuclear halo. So which is characteristically, as you might have read, is called the owl's eye appearance. Then there is something called as a Hodgkin cell, which is basically a mononuclear variant that of the Reed-Sternberg cell that is just having a single nucleus, but it also has a very prominent eosinophilic nucleolus in it. So together we refer to them as the Hodgkin-Reed-Sternberg cell or the HRS cell. And when these Hodgkin-Reed-Sternberg cell undergo apoptosis, they form something called as the mummified cell or the pycnotic cell. So let's see some pictures here. So this cell right in the middle that you can see here, you see this cell, this has this large cell which has this 2 nuclei in it, and each of this nuclei have a very dark eosinophilic nucleolus in the center, and they have a large cytoplasm surrounding them. And you can see, if this is a normal lymphocyte that is surrounding it, you can fit at least 5 to 6 lymphocytes in it, in this cell. Like you can fit these at least 5 to 6 lymphocytes in it, so it's almost 5 times the size of a lymphocyte. So this is the typical Reed-Sternberg cell. So now, but let's look at this cell. You see, let's focus on this cell here. So this cell just has one nucleus and a very prominent eosinophilic nucleolus. This looks exactly like the Reed-Sternberg cell. The only difference here is that it is mononuclear. So we will call this the Hodgkin cell. And then this here, when the Hodgkin cell and the Reed-Sternberg cell undergo apoptosis or pycnosis, they form something called as mummified cell. What does that mean? That means that the nucleus undergoes pycnosis, that is, you cannot really see what's happening inside it. It becomes very dark. The cytoplasm becomes very eosinophilic. It is basically that the cell is dying. So the mummified cells are also a feature of Hodgkin lymphoma. So let's now talk about the various subtypes of classic Hodgkin lymphoma. So let's first give you a bird's eye view of the 4 subtypes. So we have the nodular sclerosis, we have the mixed cellularity, we have lymphocyte rich, and we have lymphocyte depleted. Let's first talk about nodular sclerosis. An important feature of nodular sclerosis type of Hodgkin lymphoma is capsular fibrosis. And as the name suggests, sclerotic bands which are separating the lymph node into nodules. So capsular fibrosis and sclerotic bands. And then we can see the characteristic Hodgkin Reed-Sternberg cell, and there's something called as the lacunar cell. So what is lacunar cell? It is basically similar to an Hodgkin Reed-Sternberg cell. It just has cytoplasmic retraction because of our processing of the tissue. So there is kind of like a white space around it. So it looks like that the cell is lying in an empty space or a lacuna. That is why we call it as a lacunar cell. So these are our neoplastic cells. Now the background, which is non-neoplastic, consists of eosinophils, histiocytes, lymphocytes, and neutrophils. These are important because the background helps us differentiate it from the other subtypes as well as the sclerotic bands. So there is a syncytial variant of nodular sclerosis where there are sheets of Hodgkin Reed-Sternberg cells, and necrosis may be seen, especially where the tumor cells aggregate. I'm sorry about that. So then we have the next variant, and I will show the histology as well. Let's first go over the data here. So next variant is the mixed cellularity type. Important thing, there are no sclerotic bands or capsular fibrosis. There are again increased number of Hodgkin Reed-Sternberg cell as compared to the nodular sclerosis type. And again, you would notice that the background also contains eosinophils, lymphocytes, histiocytes, and plasma cells. So how do we differentiate this from the nodular sclerosis variant? Because if you see, the nodular sclerosis variant also contains eosinophils, histiocytes, lymphocytes, and also might contain some neutrophils. So again, the important thing becomes the sclerotic bands and the capsular fibrosis. If you have thick sclerotic bands which are forming these nodules, and then there is a thick capsule that is more pointing towards the nodular sclerosis subtype, whereas if you have like kind of a diffuse growth which has a background of eosinophils, lymphocytes, histiocytes, as well as increased number of Hodgkin-Reed-Sternberg cell, that points more towards a mixed cellularity type of subtype of classic Hodgkin lymphoma. In EBV positive cases of mixed cellularity type, the epithelioid histiocytes or granulomas can be seen, and pardon the spelling error here. Then let's go on to the next subtype, which is the lymphocyte rich. So again, as the name suggests, it is rich in lymphocytes. So the background will be rich in small lymphocytes. So it has a nodular or a diffuse pattern. Again, it has Hodgkin-Reed-Sternberg cells, which may resemble the LP cells. So what is LP cell? LP stands for lymphocyte predominant cell. So this type of cell is seen in another type of Hodgkin lymphoma, which is the nodular lymphocyte predominant Hodgkin lymphoma, which is a differential for classic Hodgkin lymphoma. So those are the characteristic popcorn cells, and we will talk about the nodular lymphocyte predominant Hodgkin lymphoma in another video. So, but it can also contain cells which are very similar to LP cells in the lymphocyte rich variant. Again, important thing, the small lymphocytes form the majority of the background in the lymphocyte rich variant, and they are usually B cells. So important thing to remember, in other subtypes of classic Hodgkin lymphoma, the background lymphocytes are T cells, T as in toy. Whereas in the lymphocyte rich subtype of classic Hodgkin lymphoma, most of the background lymphocytes are B cells, B as in boy. Another thing is that eosinophils and or neutrophils should not be present inside the nodules. They may be present at the periphery of the nodules if this variant is forming nodules, because as you can see, it can form diffuse pattern as well. But if it has a nodular pattern, you might see some scant eosinophils or neutrophils at the edges of the nodule, but they should not be present inside the nodule to call something as lymphocyte rich variant. Let's go on to the other one, that is the lymphocyte depleted. Again, it contains Hodgkin-Reed-Sternberg cell, and as the name suggests, it is depleted of lymphocytes. In fact, it is depleted of other immune cells in the background, so it has very scarce background lymphocytes. There are two patterns which can be seen in the lymphocyte depleted variant. There can be sheets of Hodgkin-Reed-Sternberg cell, or there can be a diffuse background of fibrosis, histiocytes, and scattered Hodgkin-Reed-Sternberg cells within the diffused background fibrosis. Importantly, the fibrosis in the background is diffuse and is not forming sclerotic bands, because sclerotic bands are a characteristic feature of nodular sclerosis subtype of classic Hodgkin lymphoma. So all of these are the four subtypes that we are talking about. So let's now go to the immunophenotype, and the immunophenotype of the Hodgkin-Reed-Sternberg cell is similar in all of these four different subtypes of classic Hodgkin lymphoma. Importantly, these are CD45 negative, and this immunophenotypic characteristic is very important because, as we will see in the differential diagnosis, this will help us differentiate it from the nodular lymphocyte predominant Hodgkin lymphoma and even the other differentials which we will go over in the differential diagnosis. CD30 is usually positive. CD15 is also positive, but it may be negative in some cases, and both CD30 and CD15 have kind of this Golgi staining pattern. PAX5, very importantly, is dim. So now think of these Hodgkin-Reed-Sternberg cells, or this classic Hodgkin lymphoma, as a B cell lymphoma which has forgotten that it was a B cell and has a very dim memory that, oh, probably in my previous life I was a B cell. So all the B cell markers will be negative except PAX5, which will be dim. And this PAX5 dim is very important, because if you have a case that you're suspecting as classic Hodgkin lymphoma and it is dead negative for PAX5 or very bright for PAX5, always reconsider or always take one step back and make sure that all other markers are falling in place before calling something as classic Hodgkin lymphoma. So pax5 dim is a very important marker. CD20 is usually negative, but it may be weakly positive in a subset of cells in about 30 to 40% cases, but other B cell markers like CD19, CD79A, 22 are negative. MUM1 is a usually very helpful marker because it is brightly positive in the Hodgkin-Reed-Sternberg cells, so very brightly positive. So CD138, which is a plasma cell marker, is negative. Importantly, OCT2 and BOB1 are negative. These become very important because these are very brightly positive in nodular lymphocyte predominant Hodgkin lymphoma, and we will go over that later. BCL6 is negative. EBV can be positive or negative. EBV is usually positive in the mixed cellularity and the lymphocyte depleted subtype. Another important marker is GATA3 and STAT6. They are positive in about 80% of the cases, and this can help again be a helpful marker in cases where we are between two or three differential diagnoses. Again, as I was talking about, majority of the lymphocytes in the background are T cells, except in lymphocyte rich type where B cells are predominant. But important thing, the cells that form the rosettes around the Hodgkin-Reed-Sternberg cell, which is also seen in lymphocyte rich variant, are always the T follicular helper cell type, which are CD4 positive, PD1 positive, ICOS, and CD10 positive. So what this means, majority of this lymphocytes in most of the subtypes of the classic Hodgkin lymphoma are T lymphocytes, except in lymphocyte rich subtype where the majority of the background lymphocytes are B lymphocytes. However, even in the lymphocyte rich variant, if there are some lymphocytes which are forming rosettes, so what we mean by rosettes, that is, suppose this is a Hodgkin-Reed-Sternberg cell that we are seeing in the middle here, you might see some lymphocytes that are encircling those encircling those Hodgkin-Reed-Sternberg cell. So these lymphocytes will always be the follicular helper T cells, regardless of the background. CD21, it highlights follicular dendritic meshworks in the lymphocyte-rich variant. So this is the immunophenotype which you must keep in mind because this is very helpful in distinguishing it from various subtypes. Now let us see some morphology. So this is the case that we have. Here we see there are these nodules of blue tissue here, and then there are these thick bands of pink tissue here. So these thick bands of pink tissue are the sclerotic bands. So this is like sclerosis that is separating the tissue into nodules of these lymphocytes here. And even at low power, you can see that there are some white open spaces within these lymphocytes here. So let's go on to some higher power here. And what we see this classic Reed-Sternberg cell in the middle. As you can see, it is multinucleated, having two nuclei, and it has a bright eosinophilic nucleolus in the center, which is a characteristic owl eye-like appearance. And then there are background of small lymphocytes and histiocytes that we can see here. Then there is another view from the same tissue. We can see more different morphologies of the Hodgkin cell or Reed-Sternberg cell. This kind of looks like a lacunar cell because there is some white space around it, but it doesn't have the characteristic eosinophilic inclusion, so it can also look like a lymphocyte predominant LP cell. As you can see, there are more of these cells here, and there is a background of small lymphocytes. But if you search along, you will always find some eosinophils in the background as well, which you can see here. So there's background eosinophils, lymphocytes, histiocytes as well. There might be some scattered neutrophils as well. Let's go down, and here we see these characteristic mummified cells here, which have this dark pycnotic nucleus, eosinophilic cytoplasm. There are quite a few mummified cells that you can see here. Again, there is a background. There might be some eosinophils here. There might be like here. Then there might be lymphocytes and histiocytes in the background. Then they characteristically have that sclerotic bands and nodules. So this is pointing me towards classic Hodgkin lymphoma, which is a nodular sclerosis subtype. But we still have to do the stains. This is the CD45 stain. As you can see, this large cell in the middle is negative for CD45. Now you may say that you can see some staining at the edges here. So is it the membrane of this cell that is staining? Well, actually, if you notice, this is actually the membrane of the surrounding cells which is staining, because if you see, when there is no cell here, there is no staining here. So that is why we say that this is CD45 negative. CD30, which is characteristically very brightly positive, which has this characteristic Golgi, which is, so what we mean by Golgi, if you look at this cell here, there is this membranous staining, and then there is this Golgi staining here. So this is CD30 positive with the Golgi staining, as you can see here as well. Then we go on to CD15. The CD15 in this case was kind of weak, but again having this characteristic granular staining in the Golgi as well. Then we have CD20, which, if it is nodular sclerosis subtype of classic Hodgkin lymphoma or any subtype of classic Hodgkin lymphoma, should be negative, and it is very nicely negative, as you can see in this large cell here, which is CD20 negative. Let's move on to the very important marker, that is PAX5, and this is the characteristic Reed-Sternberg cell, which is PAX5 dim. This cell again, then this cell. And how do I say that this is PAX5 dim? Just compare it with the surrounding B cell. If you see this cell, this is a B cell here. This B cell is very bright for PAX5 compared to it, like for example this cell or this cell, they are dimmer than the actual B cell. So this is what we mean by PAX5 dim, and this is a very important finding here. And I'm sorry, this has been mislabeled. This should be CD3. This is the CD3. We just do a 20 and 3 for the completion of our markers, and you can see that it's staining a large amount of T cells as well in the background, but our larger cells are negative for CD3. And then this is MUM1. MUM1, as you can see, is very brightly positive in these larger cells, which are the Hodgkin Reed-Sternberg cells. So this is a case of classic Hodgkin lymphoma, nodular sclerosis subtype. Now, differential diagnosis, always in differential diagnosis, we have the nodular lymphocyte predominant Hodgkin lymphoma. And here immunohistochemistry really helps us. As you can see, CD45. So basically the immunohistochemical staining profile of the nodular lymphocyte predominant Hodgkin lymphoma is exactly the opposite of the classic Hodgkin lymphoma. So classic Hodgkin lymphoma was CD45 negative, nodular will be positive. Classic 30 positive, nodular will be negative. Classic is 15, can be positive negative, nodular will be negative. PAX5 dim expression in classic, it will be positive in nodular lymphocyte predominant. CD20 iffy, may or may not be positive, usually brightly positive in nodular lymphocyte predominant. MUM1 was very strong in classic Hodgkin lymphoma, whereas in nodular lymphocyte predominant, it is variable to weak. OCT2 becomes now very important. OCT2 is a very good marker for nodular lymphocyte predominant Hodgkin lymphoma, as well as BOB1. These two are positive in NLPHL and negative in classic Hodgkin lymphoma. BCL6 again is positive in nodular lymphocyte predominant Hodgkin lymphoma and negative in classic Hodgkin lymphoma. EBV may or may not be positive in certain subtypes of classic Hodgkin lymphoma, but it is usually negative in nodular lymphocyte predominant Hodgkin lymphoma, and there are very rare cases where it may be positive, but usually negative. Other differential includes T cell histiocyte rich large B cell lymphoma. Again, immunohistochemistry would help here, because the Hodgkin Reed-Sternberg cell are usually negative for all B cell markers except for PAX5 dim, whereas this is a large B cell lymphoma, so it will show all B cell markers. Again, CD21 will also help if we are kind of caught between the lymphocyte rich variant of classic Hodgkin lymphoma and T cell histiocyte rich large B cell lymphoma, because the lymphocyte rich variant would have CD21 positive FDC meshworks, whereas the T cell histiocyte rich large B cell lymphoma won't have that. Then again, EBV positive diffuse large B cell lymphoma, again it is a large B cell lymphoma, so it will express all the B cell markers, which the classic Hodgkin lymphoma won't. Mediastinal gray zone lymphoma can become very difficult, and when do we suspect a gray zone lymphoma? When it is having aberrant expression of markers. For example, there are certain markers that are going more towards a classic Hodgkin lymphoma, but then there are certain markers that are going more towards a diffuse large B cell lymphoma. So it is a very difficult diagnosis to make, and usually requires consensus. Then there is nodular T follicular helper cell lymphoma, angioimmunoblastic type. So this is basically a T cell lymphoma. So here the background T cells are neoplastic, unlike the classic Hodgkin lymphoma where the background T cells are not neoplastic. So T cell gene rearrangement studies can be very helpful here as well. And there can be other T cell lymphomas like anaplastic large cell lymphoma, peripheral T cell lymphoma, which can show Hodgkin Reed-Sternberg like cells. So T cell gene rearrangement as well as clinical history, they all are very important. So just to summarize, classic Hodgkin lymphoma, germinal center a B cell neoplasm. And just to give you a bird's eye view, we have 4 subtypes of classic Hodgkin lymphoma: nodular sclerosis, mixed cellularity, lymphocyte rich, lymphocyte depleted. Important, has characteristic Hodgkin Reed Sternberg cells, can have lacunar cells and mummified cells. Important markers usually, so just remember, they are B cell lymphomas, which have forgotten that they are B cell lymphomas. So negative for all B cell markers except for PAX5, which will be dim. Usually positive for 30 and 15, negative for 45. They're importantly negative for OCT2 and BOB1, which are also B cell transcription markers, which help us to differentiate it from nodular lymphocyte predominant Hodgkin lymphoma. And that is it for today's video. I hope you have a great rest of your day, and please let me know if you like the video, and thank you so much for your attention.